Hi, everyone. I'm Lisa McGovern, Executive Director of the Prevent Cancer Foundation's Congressional Families Program. Let me begin today by thanking everyone here in studio and all of you watching from your home, office, and mobile devices as we explore what your zip code says about your health and risk of cancer. I also want to thank the National Association of Broadcasters for sponsoring the Congressional Families Program throughout the year and for hosting today's webcast. You are making it possible for us to reach a much wider audience of congressional spouses and staff nationwide. For those of you not already familiar with the Congressional Families Cancer Prevention Program, we are a bipartisan, bicameral group of congressional, diplomatic, and administration spouses working to increase the public's understanding of cancer prevention and early detection. This unique program was founded way back in 1991 as a partnership between the Prevent Cancer Foundation and the Congressional Club. As spouses, now representatives, Representative Doris Matsui and Representative Debbie Dingell were among the founding members, and today they are among the many members that are involved with our program. The Congressional Families Program offers elected officials, spouses, and other family members educational events and seminars, op-eds, letters to the editor, and other tools to spread the Foundation's mission of cancer prevention and early detection to communities across the country. Today, in observance of National Minority Health Month, we will discuss social determinants of health. Often in seminars, we talk about the importance of getting cancer screenings, eating healthy, or exercising for cancer prevention. But not everyone has equal access to the resources that make these steps possible. Many people are focused on getting their basic needs for food, clothing, and shelter met. Making healthy choices can feel like a luxury. Congressional Families has a unique opportunity, and we're in a unique position to raise awareness about these challenges because we have members from every state and many districts, so we represent the wide disparity that exists across the country. Part of preventing cancer is understanding how where you live can create obstacles and developing strategies to break down those barriers. Today, we'll take a deeper look at how your zip code affects your health and cancer risk and ways some communities across the U.S. are working to overcome these disparities. This is an important topic that we would not be able to explore without the support of our program sponsors. So, in addition to the National Association of Broadcasters, we'd like to thank Bristol Myers Squibb, AZI, and Pfizer for their support. Now, to help us frame and moderate this discussion, I would like to introduce Maggie Fox, senior writer at NBC News covering medical and health issues. Maggie has been writing and reporting about and editing health and science news for more than 20 years. Including at Reuters and National Journal, and we are very fortunate to have her with us here today. Welcome and thank you, Maggie.
Thank you, Lisa. This is such an important issue, what your zip code says about your health. We know that where you live is every bit as important for your health as who you are. We know that people who live in West Virginia or Kentucky are more likely to die of cancer, heart disease, or a drug overdose than are other Americans. People who live in Idaho, Wyoming, and Colorado have lower rates of both cancer and heart disease. Why? As Americans, we tend to think of personal choices such as healthy eating, not smoking, exercise, and seeing a doctor. But it's becoming very clear that communities and society in general can give people choices or take them away. High-quality education, income, and even living in a safe neighborhood can and do affect people's health. As Lisa pointed out, not every American has access to good schools, to parks and sidewalks, to good doctors and hospitals, even to a grocery store that sells fresh produce. These types of things can lead to health disparities, and they can affect health equity. This is what our two panelists will tell us more about. These disparities can come for many different reasons, not just zip code, but because of race or ethnicity, religion, income, sex, age, mental health, disability, sexual orientation, or gender identity. When there are disparities, it can cost all of society. In the end, everyone pays for health care, whether it's through taxes or health insurance premiums. If people can't get their cancer treated and show up at the ER as emergency patients in the late stage of disease, the hospital has to take care of them, but those costs get passed along to everyone. And in a country that's about equal opportunity for all, it's important for us all to make sure that these opportunities truly are equal. Our two experts are going to tell us more about these issues. First up, Dr. Sherry Flint Wallington. Dr. Wallington is an assistant professor at the Lombardi Comprehensive Cancer Center at Georgetown University, where she studies health communication, health promotion, and community-based participatory research strategies and how they affect social determinants of health, cancer prevention, cancer health disparities, and clinical trials. She has special interest in prostate, breast, and cancers caused by the human papillomavirus, or HPV. Dr. Wallington will tell us about the causes of cancer disparities in cities.
Thank you. Thank you, Maggie, Lisa, for inviting me. I'm happy to be here. I'm going to talk a little bit about social determinants of cancer disparities in urban populations. And in the full interest of disclosure, I grew up on a rural farm, so I'll have knowledge of what it means to grow up in a rural area, but I'm going to let my wonderful colleague, Dr. Electra Paskett, talk about that. When we talk about social determinants of health, it's important that we understand and try to define what social determinants of health means. And there are many definitions, but the World Health Organization defines social determinants of health as the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. Some U.S. examples are employment conditions, gender inequality, racial, economic, class, religious exclusion, and also social systems where we include housing, public policy, health systems that often increase the risk in certain groups, but can be used to address those risks as well. So social determinants of health, I really like this framework by our U.S. Healthy People 2020 initiative that really focuses and emphasizes a place-based organizing framework that includes 5 key areas, and those include neighborhood and built environment, economic stability, education, social and community context, and certainly health and healthcare. And I'll use the District of Columbia as an example. And so one of the mainstays in the District of Columbia is our public transportation system in Metro. In urban communities, some of the things that characterize urban communities are mass transportation and public transportation, as well as tall buildings, density, population per square mile. And so when we look at the DC, you can about map these disparities and the impact of these social determinants of health, by the different metro lines. So you see with the red, which would be the red metro line, you see high breast and prostate cancer rates and also food deserts. And then in other areas, you also see similar incidence and high mortality of cancer rates. But you also see some of these other social determinants of health that really impact people's health in these different quadrants of DC, such as food deserts. And food deserts is one of the things that you really see a lot in many urban communities. So if you look at this first map, you will see the high prevalence of red in that area where we have a lot of localized food deserts. In the second map, you see the purple, the dark purple color. That's indication of communities that have little access to transportation or no car. And then the pink area, you also see again areas in the district that also are impacted by food deserts. And food deserts basically where there's an insufficient amount of access to fresh foods. And some of my work involves going into DC communities, and I'm always impacted by the stories of community members that share. And I asked a woman doing some focus groups, how long, in her opinion, would it take her to get access to fresh fruits and vegetables? And she said that she would have to take 2 buses and a train to reach a grocery store where she felt like she could access fresh fruits and vegetables. And so certainly the time that it would cost, and also it costs more to eat healthy, impacts a person's health. Okay, let's see. So some of these costs also look at who's affected. And so we talk a lot about gender inequalities, also racial, ethnic inequalities, but also looking at the economic and societal cost of cancer disparities and how these social determinants of health impact these disparities. And as you can see, the costs are great. The estimated annual cost of racial ethnic disparities, you can see 193 billion, and the costs keep escalating, and we see similar types of high costs as it relates to racial disparities as well. And these relate to fewer disability days, more hours worked, higher wages for working age adults. And when we look in urban communities, we can also see gender inequalities. When you look at DC as an example compared to national US rates, you see that DC among men has a high incidence of mortality, women higher than the US national rate, and then also differences in white and black. But what's interesting about DC, white residents of Washington, DC experience lower rates of cancer and cancer health deaths than whites across the United States, while the cancer death rate for Black residents is significantly higher than it is for Blacks nationally. And these are important areas of concern and areas that need to be addressed. And using a social determinants of health lens to help break down, what these areas of concern are and causes, and look at possible ways that we can intervene are so important. So some of the things I think we can do as far as policy recommendations, improve and expand medical insurance coverage, although we do have the Affordable Care Act. In many minority and underserved populations, they still struggle with high co-payments and those kinds of things. Also reduce geographical disparities through community level interventions. Many community members say they can't afford to travel very far to participate in programs and interventions, that having community-based interventions right where they live would be really helpful. In one quadrant of the city in Southeast DC, we've seen great success with community gardens, teaching community members and really entire families, the importance of what it means to eat healthy and how they can eat healthy on their budget. And then also sponsor and fund more research on how to intervene on mechanisms that are especially modifiable factors contributing to poor health outcomes among racial, ethnic minorities and differences across social demographic groups. So thank you.
Thank you, Dr. Wallington. Dr. Electra Paskett is the Marion N. Rowley Professor of Cancer Research at The Ohio State University. She's also the Director of the Division of Cancer Prevention and Control in the College of Medicine, Professor of Epidemiology in the College of Public Health, and the Associate Director for Population Sciences and Program Leader of the Cancer Control Program at Ohio State's Comprehensive Cancer Center. Dr. Paskett focuses on cancer prevention, early detection, and survivorship. She talks to people out in the communities to find out what causes disparities and what we can do about them. Just last week, Dr. Paskett was given the Prevent Cancer Foundation's Laurels Award for increasing health equity. She'll tell us more about how where you live affects health disparities with a special look at Appalachia.
Good morning, and thank you very much, Lisa, for that introduction, and Maggie, Prevent Cancer Foundation and Congressional Families, for inviting me to tell you a little bit about the work that we do and the population that I work with in rural and Appalachia, Ohio. Appreciate Dr. Wallington's also introduction a little bit, and I'm going to expand upon this in terms of what we see in Appalachia, in terms of how place impacts disparities. So when we talk about place, what does that mean? Well, place is where a person lives, where they learn, where they work, where they play, and where they worship. Synonyms are a location, a site, a spot, a setting, position, area, region, locale. And when we talk about geographic options, those are countries, our state, our area, county, city, town, etc. So those are sort of what we think about when we think about place. So how does place impact your health? Well, this is a lovely cartoon that I came upon, and you can find your home state, but if we look at the ones that are easiest to read, we can see California is known for its most smog, Alaska, most airports per capita. So you can find your favorite state and see what they're most known for in terms of what makes your state not excel. So why does place matter? Why does where you live impact your health? I'm just going to talk very briefly about a few reasons. First of all, we know that people are exposed to certain environmental exposures based on where they live. And these could be toxins, for example. If you live near a river that has been contaminated, chemicals, or the sun. And this graphic shows latitude and vitamin D production. And we know that the sun is very important for vitamin D production. Where you live impacts culture, policy, and economic factors. And this cartoon here shows you where there are cities and counties in 18 states that have now implemented the Tobacco 21. Promotion of risky behaviors. We just heard about food deserts, and this map shows us where food deserts are most prevalent. But they also impact advertising and crime. And quality of care. This map of Texas indicates where the colonoscopy facilities are located. And you can see there are fewer the more rural you get in Texas, or more west. And segregation. And Dr. Wallington talked a little bit about wealth, power, and position in terms of the social determinants of health. And this shows the racial segregation that we see in the area around Buffalo. This is another map. This is a paper that was published in 2015, but it shows colorectal cancer mortality or death rates, hotspots over time. And you can see in the top left, the red indicates the higher rates of death. And slowly over time, if you move to the right, then down to the left, those red areas become less and less until the most recent, which is the bottom right, shows you 3 distinct areas where colorectal cancer death rates are the highest in the country. And that middle region includes areas of Appalachia. So I'm going to tell you just for a second a little bit about my state, Ohio. Ohio has a population of almost 12 million. There are several urban areas and also many rural populations that include the northwest area, but also the gray shaded area, which is Appalachia. It's a 32 county area in east and south. Appalachia was a federally designated healthcare professional shortage area and was designated by President Johnson as part of the war on poverty as a socioeconomically distressed area. And this is the region in the United States. It spans 420 counties across 13 states along the Appalachian Mountain area. and it still has areas of socioeconomic distress. When we focus on disparities, we also use the social determinants of health, which is a socioecologic framework. But one nice thing about the social determinants of health framework is that it says that the causes of, and thus the solutions to, disparities are multifactorial, meaning multiple causes, and multi-level. And I'm going to show you an example of this in just a minute. But these levels go from biology all the way up to policy. And they all interact with each other and influence disparities. The interventions then can be directed to one or more of these levels. And when I was part of the Centers for Population Health and Health Disparities, which was a National Cancer Institute initiative, we developed a model, which we lovingly call the Warnecke Model, after Dick Warnecke, that explains both the social determinants of health, the biology to policy, and how the levels interact. So I'm going to walk you through this model using a real example. So why do we see disparities or differences, higher rates of death from lung cancer in Appalachia? Is it just because they smoke more? The answer is no. They live in states with low tax and greater production of tobacco. So you can see here on this map, Kentucky has a lower rate of tobacco tax, higher rate of tobacco production. Smoking is more likely to be allowed in workplaces, or workers can get smoke breaks easier. We at Ohio State have done some research and actually went out and had our students measure the tobacco ads in the convenience stores in Appalachia. And the ads are more prevalent and larger in convenience stores in the Appalachian region compared to the urban region. You have family members or friends who smoke. Again, our research, we found that smokers are more likely to have social networks with smokers. It's harder to smoke when everybody you socialize, harder to stop smoking when those around you smoke. And what we heard time and time again from the residents that we interviewed is that there's so much stress in living in the economically deprived areas that smoking and alcohol use are used to manage the stress. And the rates of binge drinking are extremely high, as well as the rates of depression in these populations. And then when we're down, let's get down to the bottom level, which is biology. We know that some populations, some people, have a genetic susceptibility to addiction to the nicotine, or specifically if we're talking about African American populations, a genetic susceptibility to prefer menthol, and then that makes it harder to stop smoking. So again, all of these interact to keep a person smoking, increasing their risk for lung cancer. So how can we reduce or eliminate disparities? And with our example of smoking, keep people from smoking or stop them from smoking. Well, let's use the model again. We can increase tax on tobacco, and we know that policies like this drive cigarette sales and drive the smoking rates down. California has successfully demonstrated that. Enforce workplace anti-smoking policies. We know that those also work. Decrease tobacco cues in the environment. So this is a barn in Kentucky, a tobacco barn. And in Appalachia, you'll see them all over because tobacco is grown in these areas. And usually they will advertise tobacco, male pouch tobacco, etc. And this is a great example in Kentucky of talking about not smoking on the barns. When you're getting a person to smoke, use family-based smoking cessation programs and offer doctors need to offer, to ask, advise, refer to smoking cessation programs. And that a lot of times is not done. We need to offer smoking cessation programs. And we need to use combination therapy. We can use medication combined with behavioral cessation therapy in order to have people quit and stay quit. Well, thank you very much.
Thank you, Dr. Paskett. Thank you, Dr. Wallington. You all both gave us really provocative things to think about. Your presentations are great. I absolutely love the maps, both of them, the subway map, the metro map in DC, and the map of your favorite state and what you're famous for. Dr. Wallington, I'd like to go back to the map that you showed us of the metro, and Dr. Paskett, your map as well, because both of them showed the importance of transportation in reducing these disparities. And it's two different things, because when you think of people living in cities, you think, well, they can walk to things, they can get on public transport, they have buses. And when you think of people who live in rural areas, you think, well, everybody's got a car. Why can't they get to where they need to go? Can you, each of you, explain a little bit more about why access to good transportation is so important in eliminating some of these disparities?
Well, in urban populations, as you just said, you typically think that that wouldn't be an issue because there's mass transportation, there's buses, but there are certain quadrants of urban cities that don't have access to transportation. So for instance, in the District of Columbia, the district is split up into wards. And for instance, we know that Ward 8, which is in the southeast quadrant of the city, you see a lot of seniors there. You see a number of people who don't have access to cars. And then also simply, many people can't afford the metro cost. Over the years in the District of Columbia, like in many urban cities, these public transportation costs have increased and still increasing. So just for instance, this morning, I took the metro and there's a sign posted there that's saying the metro will be going up, so much in this summer. And then there's also a cost to even park at the metro. And so when you don't have good transportation, access to transportation, or reliable transportation, that impacts your access. So it's about the link between transportation, your access to be able to get to a grocery store that offers healthy food, or more importantly, access to health care. If you have to take 2 buses and a train, as I told the story of a grandmother who's raising her grandchildren just to get what you feel is fresh fruits and vegetables, you may say, that's too much of a burden on me. I don't have a car. I can't afford to take 2 buses and a train. And for us, that may not seem a lot. For many families, that cost is something they worry about on a daily basis. So lack of transportation also links to not having access, to health care and those necessary resources to help keep you and your family healthy and well.
And Dr. Paskett, tell us about how that affects the rural populations.
There's no public transportation. So you have to rely on your own self with a car, or your family, or your friends. And I mentioned we did focus groups with young women. And when we were asking them to tell us, why are you stressed? They said, well, we can't get out of our houses. Mm-hmm. And we have no cars. And even if we had a car, we have no money for gas. And then there's no place to go. So we're stuck all day inside our house. We're afraid to go outside because of the crime. So that increases the stress and links to the behaviors I talked about, smoking and drinking. There's also a shortage of healthcare facilities. So we have some counties in Appalachia, Ohio that have no mammography facility. So women, to get their mammograms, would have to go outside of the community, their county somewhere. We have several counties that have no hospital. And we have several counties that have less than 5 primary care doctors. So even if you had a car, it's hard to get to where you need to go to get help. And I have learned you can't get here from there. You have to go around the mountain. And also the area is very prone to the weather. And so if a storm comes through, drops a tree on your driveway, you can't get in or out until some neighbor comes with a chainsaw to cut the tree away from your driveway so that you can get in and out. We saw this, issue when in one county a few years ago, the only grocery store in the entire county closed. So all that was left were convenience stores. So you talk about food deserts, that was a food desert. People had to drive to the next county to be able to get fresh fruit, vegetables, and meat. So if people had the resources to do that, they could. But that significantly impacted people who have chronic diseases like diabetes, et cetera. And the last comment I'll make is, we go in there and we want to help. It breaks my heart to see this. And so now we have some grants that we can come in with our mobile mammography van. And so we bring mammography to the women. We go out in the community with community health educators and educate women about why they need a mammogram, and then we bring mammography to them. Several years ago, the community coalition members came to us and said, we have 48 women who have abnormal PAPs, and no doctor in the county will see them because they have no insurance. So I said, send them to Ohio State, we will take care of them. And they said, thank you, Dr. Paskett. If they had invasive cervical cancer, we would send them. But they have abnormalities, and we want to develop locally the resources to address our problems. I said, what do you need? So we helped them write small grants to the Governor's Commission on Appalachia. They were able to buy a colposcope, which is a device that medical professional can look at the cervix to see the abnormalities. And the health department donated space once a month for this clinic. And we had a local physician who would come, donate an afternoon to do this. And that clinic is still running today. With, the community coalition does poker runs and bingo to raise money for the biopsy forceps. But they have diagnosed and, cured several women with cervical abnormalities that would have developed frank cervical cancer if they had not been able to have this service.
Why don't you explain just a little bit more about why that's the case, why detecting a cervical lesion early helps prevent cervical cancer?
Right. So if we can detect a cancer early, we have a lot of treatment options for that person, for that cancer, for most cancers, that we can cure that person. So if we can detect the cancer early, when the cure is available and the cure will work, we can have that person be a survivor.
But even more than that, you can prevent some cancers, right? With cervical cancer, colon cancer, you can remove that precancerous tissue, is that right?
Right. So you are correct. Cervical cancer, we can remove the precancerous tissue, so it will never turn into a cancer. Colon cancer, during the colonoscopy, if they see a polyp, they can remove the polyp, and we have prevented a colon cancer.
Right, because that polyp's not cancer yet, right? It may or may not become cancer. I think a lot of people misunderstand. They think, look, I don't have health insurance. I don't want to go through the treatment for cancer, and they may not understand that this is a very simple procedure that will prevent the cancer from ever developing. And early breast cancers are similar. They're not the same, but it's a similar thing. Both of you have talked a lot about stress, and it sounds remarkably like the stressors of people in both the rural and urban communities are the same, similar stressors. Can you tell us a little bit about how stress changes their behavior and how it might affect their biology as well? Dr. Wallington?
I think there's been lots of research done on stress and the impact of how it promotes and impedes, how it impedes rather people's health and well-being. And a lot of times when you see people in the urban areas, particularly, it's stressful. The busyness of the city, just the stress of meeting their daily needs, especially among minority and underserved populations. So we know that from a biological perspective, what stress does to the body. It enables many chronic diseases, not just cancer, but high blood pressure, kidney disease, and other types of, health conditions. And so lots of interventions are being done at the community level to help people alleviate stress. And some of those that have been successful in the district that Georgetown and the Lombardi Cancer Center have done have been just getting people out to be more fit. But there's a problem because many people cannot walk in their own neighborhoods because of the crime. And so how do you bring these interventions to communities where they don't feel safe? All of the things we know that will help reduce stress, eating well, exercising, and those kinds of things. And we haven't really talked a lot about mental health. There's a lack of interventions, especially at the community level, where people need, good mental health. And I think all of these things have to be considered when we're trying to help people reduce their level of stress, which will ultimately affect their biology.
And Dr. Paskett, did you want to add to that?
When we were working in the Centers for Population Health and Health Disparities, I mentioned that initiative. We looked at stress, and Sarah Gellert, who was one of the other principal investigators on the initiative, she said stress is what gets under your skin, and this worry about how am I going to pay my rent, how am I going to buy my food, how am I, about my job or whatever. It just gets under your skin, and it has a physiologic reaction in your body. So from some research, again, that was done by the University of Chicago team, they looked at stressors and how they increase the cortisol levels in your body. And if you think of your immune system as an army of soldiers, and we'll use cancer as the example, those soldiers patrol your body. And when they see a cell that's growing abnormally, as into a precancerous condition, they a lot of times can mobilize and kill those precancerous cells or cells where the DNA looks wrong and early stages of developing into malignancy. But if those soldiers are running all over the place because of the stress, they can't attack those cells that are starting to go haywire. And so that's what stress does at the cellular level or the physiologic level, is that your body is always at a heightened state, and it cannot concentrate on regulating cells that have gone crazy.
Is that what we talk about when we talk about inflammation, which is linked with cancer and heart disease and other conditions as well? Most cancers start as inflammation, so that there is some sort of inflammatory process. But that's where this army comes. The army is called, and there's a battle that happens, and that sometimes causes inflammation. So if the soldiers can't win and the cancer wins, then it will continue to grow. Both of the issues that you all have outlined, rural versus urban, a lot, it sounds like to me, relies on socioeconomic factors. Appalachia, maybe we should talk a little bit about how Appalachia got so poor. Urban areas, especially DC, how did some of these neighborhoods get to be so neglected by the rest of the world and so concentrated? And maybe we'll start there, Dr. Wallington. How did DC get so literally segregated?
I guess that will be, just looking at a long history of the city. But it has to do, I think, a lot when we look at these social determinants of health, where people live. And as you see in many urban cities, you see many urban cities are going through gentrification. So you see changes happening as we see a change in how our demographics are shifting. Some of that speaks to that. Also, when you look at people's ability to build income and wealth, that's tied to that. And typically you see that minorities and underserved populations, over history, they have not been able to build the social capital and wealth like other groups, so to speak. And so that ties into their ability to have access to certain resources. And when you don't have access to certain resources, that's going to affect your social economic status, where certain groups are not moving up along the socioeconomic ladder like other groups. And so that impacts their ability to have access to the best health care, live in the best neighborhoods. We know that where people live and the neighborhoods they live in impact their health, the resources in those neighborhoods. And so sometimes in order to change that, we need policy changes and recommendations that say, for instance, if you're living in public housing, there are certain standards that have to be applied to public housing so that people are living in livable conditions. So all of these things are linked together so that people that along the socioeconomic status is equitable. Okay, and so that you don't see different communities or neighborhoods having more than others. And I think that's one of the things when you look at when the U.S. Census does that census, one of the things that they're tracking is to see in these different neighborhoods and these census tracts what hospitals are available. Electra talked about one township or community not even having access to a mammography center, the hospital closed, and what a devastating effect that can be, on people's health. And so more policy is needed, more programs, and we need more ways that we can measure and track these differences so that we don't see all of these inequalities that we see.
And Dr. Paskett, how did Appalachia get in such trouble?
Well, you can look at a little bit about the settlement of Appalachia in terms of who went there. Early on, they were the poorer people that were looking for a place to settle. And they settled in the mountains. It's a beautiful place, settled in the mountains. And they wanted, their farms to be able to farm the land, take care of themselves. And a lot of companies came in and started the coal mining and things like that. And so the people started working in the coal mines. And the people didn't own very much. The other people who came in to develop the coal mines are the ones that owned most of it. And in addition, some people started selling the rights to the minerals on their land, so that when they got some money for doing that, but when the companies left, there were no more minerals in the land, so they couldn't farm. It's also an isolated area, so it's hard to get things in, and also, I keep saying this, and a lot of people don't believe me, but you can't get good internet service there. Even though, the federal government has been trying. Now there's a new initiative with the Federal Trade Commission, I believe it is, and the National Cancer Institute to try to reinforce internet connectability. But I would be there in the church basement recruiting people to my diet and exercise program, and have a hotspot going on my cell phone, on the laptop, and the hotspot, loses connection. People are still using dial-up, and in some places, it's dead. You can't get any reception. So that there really is, the geography makes it hard for certain things to come in. And then, the healthcare professionals, the doctors, are not necessarily better economically with their practices than the rest, of the communities. And some places, were right next to the creek, and the creek would rise every spring, and they'd get flooded. And I think, can they not move their office? Well, no, they can't, because they're just, the same. They're providing care to people there, and they don't have necessarily the capital to move either. So the Regional Commission on Appalachia helps with several things, but it's really an area that needs a lot of attention.
So, Electra, really, there's a digital divide, a technological digital divide there as well.
There is.
There's one subject that we haven't talked about yet, and that's preventing cancer. And a good way to prevent cancer that we know about is the HPV vaccine. Can you talk about if there are particular challenges in educating people about the HPV vaccine, getting it to them, helping make sure they get all the doses of the vaccine that they need? And maybe you can start, Dr. Wallington.
Okay, a lot of my work has been around educating parents, adolescents, and providers about HPV and HPV vaccination. And as many know, that in 2009, the District of Columbia passed legislation that said that girls going into the 6th grade, and now boys, have to receive the HPV vaccine or opt out. And so I think that one of the biggest barriers we saw initially, as Electra and I have talked about at other forums, is that providers were not recommending the vaccine, for some for their own personal reasons, some because they themselves were not fully knowledgeable about HPV and the HPV vaccine. And so there have been many, many national efforts to really ramp up provider education, and I think that has really helped. And I think really just helping also parents make an informed decision. In the U.S., if you look at the history of vaccines, and I had a mentor a couple of years ago give me the complete history of how the polio vaccine, was developed, and that really, really helped me. And one of the opposition is that I hear in the community is that, well, this vaccine is so new. Well, no, it's not so new now, because we have almost over 10 years of good science behind the HPV vaccine, and millions of doses have been distributed and given out, and with very few side effects. But I think with working with parents, what they really want to know is this vaccine safe? And many people just think that HPV is linked to cervical cancer, but we know there are other HPV types of cancers linked to HPV, and just educating that. And I think what has really helped, I think early on, a lot of the promotion and advertising was linked to girls, and framing it so that the communication is gender neutral, that this is something that affects both males and females, and framing the communication around that has really helped parents to understand that this is a cancer prevention vaccine. And how great is that in our time we can talk about a cancer prevention vaccine, and I just think that that's awesome.
And Dr. Paskett, you're talking about not getting access to Pap smears or treatment for abnormal Pap smears. If everyone got the HPV vaccine, the need for Pap smears is not going to go away, but it's going to be greatly reduced, correct?
That is correct. We're actually moving to testing for HPV on a longer schedule, so that will help. But we have to pair that with HPV vaccination. And Dr. Wallington is right. It's cancer prevention, and we have to think about that. I'm a cancer survivor, a breast cancer survivor, and if we told the public we had a vaccine to prevent breast cancer, people would be lining up around the corner. And here's a vaccine that can keep people from hearing, those words, "you have cancer," those 3 words. My mother was a cervical cancer survivor, and a lot of, still today, there's a lot of, blaming, stigmatization for people who have cervical abnormalities and cervical cancer. But it shouldn't be, and we shouldn't have any more cervical cancer. In fact, many agencies, including the WHO, have called for the elimination of cervical cancer. Can you imagine that? Eliminating a cancer, possibly up to 6 different types of cancer, because of the HPV is related to several other cancers besides cervical cancer. We've virtually eradicated polio from the world because of vaccination. So could we do the same thing with a cancer by vaccinating for HPV? And the same things we hear in Appalachia. Parents haven't heard of the vaccine, especially for boys. There's a lot of concerns about safety. And it has been given to millions of adolescents across the world with no more side effects than what we see for the other children's vaccines. And it is monitored extremely closely for adverse events by the Centers for Disease Control. There's questions about the age, and boys and girls can get the shot as early as 9 and up to age 26. Now, you only need 2 shots if you get it under 15. So people say, why? Why at age 9 and 11 my child is not, sexually active? It's because we found that if you can give the shot at that age, the immune system, or those soldiers, can really gather strong in the body. And the immune system has the best effect the younger the age we can give the vaccine.
One of the things with that is Maggie and I have daughters the same age. They actually were in school together here at DC Public School, where you are required to get the vaccine or you can opt out. But one of the things about that is when they're 12, they have a bunch of vaccinations that they already get. So just to add one more in, they're already in. You might as well just have them get them all at once. Is that a good strategy to say, let's just get it done?
And that's what the CDC is targeting, is that when the children are going for their 11 or 12-year-old vaccines, which is the meningococcal and the Tdap, that the doctors say, okay, it's time for your child to get the meningococcal, the HPV, and the Tdap. It is, it's just as safe as the other vaccines. It's given at the same time. So the recommendation should be one smooth, strong recommendation. And in our research, we're in Appalachia, we have found the doctors just aren't making the recommendation. And that's why the parents say, I didn't get vaccinated because my doctor didn't recommend. I didn't know that. In some places, we found that the supply is very short of the vaccines because the clinics, they have to purchase the vaccine and buy it for their clinic and have it there. So if they can't guarantee that they're going to use all the vaccine by the expiration date, or even use all 2 or 3 doses, then it's out of pocket for them, and that's also a hindrance. And then the myths, and we've kind of alluded to some of the myths about sexual promiscuity, and really we have to stop that. It is not anything about sexual promiscuity. It is about preventing cancer. And we talk about the HPV virus, the human papillomavirus, linked to cancer. But there are so many other nasty things that HPV causes, like genital warts, which costs a lot when we're talking about either healthcare or quality of life, and cervical abnormalities. And actually, the treatment for those can actually cause problems with fertility, ability to keep a child in the womb for 9 months, etc. So we're talking about billions of dollars in healthcare that is caused by the HPV, not just frank cancer. Because a lot of people say, well, you know, there's so many few cervical cancers in the country. Why should I, you know, give my child? Well, really, it'll prevent all of these antecedents that cost more and can impact a woman in ways for the rest of her life.
As well as head and neck cancer.
Head and neck cancer, thank you.
Which affects everybody.
And men, right now, the highest demographic for the head and neck cancer, which actually is tonsillar or the base of the tongue, the lumps will appear here in the neck, are white males in their late 50s, early 60s. And the treatment for that is excruciating, excruciating. It's a total different type of cancer than what we've traditionally seen, and it's the cancer that's now on the rise for that site.
That's a good point, actually, that I was thinking about when I had heard somebody else talking about, you know, some of the, what happens when you get one of these diseases, and when you have, you know, your children say, well, but Mom, these shots hurt. It's like, you know what? If you think this hurts, you should see what it's like to be treated for cancer. That's one of the things that I'm proud about the Prevent Cancer Foundation. We have a campaign called Think About the Link, and it talks about the links between viruses and cancer, not just human papillomavirus, but also hepatitis B and hepatitis C, which I think is so important because to educate not only the public, but the pediatricians in that case. As you said, a lot of it is just because, you know, as patients, you rely on your provider, your medical provider, sometimes to be the one that's guiding you on what you should and shouldn't do. So it's important for pediatricians to say, you need to get this shot, and you know what, you need to come back and get the second one too.
Absolutely.
Can I just make one more point about this? That you know, what we're talking about with HPV vaccination and reducing or eliminating cervical cancer is a reality, and it's a reality in Australia. And Australia has been having fabulous uptake of the vaccine in girls. And they have demonstrated, first they demonstrated a reduction in HPV, then they demonstrated a reduction in cervical precancerous lesions, and now new data show that there's actually starting to be a reduction of cervical cancer.
Isn't that amazing?
It's just, it works, it works, it works. And why aren't we in the United States up to the levels we need to have for what we call herd immunity, which is an epidemiological term. But in order to realize this elimination, we have to be over 80% vaccination for our children. My boys, I got all my boys vaccinated, and it's something that, you know, if you love your child, you want to prevent them from this terrible disease, cancer, and this is one thing that you can do to prevent it.
Yeah, and I just want to say briefly, you know, in my work with adolescent girls, hearing and learning about the HPV actually said it made them want to make better choices and delay sexual initiation. So, you know, there's other studies that say that, you know, the HPV vaccine certainly doesn't promote promiscuity, but in some cases it may help girls to become knowledgeable such that they may want to even delay sexual initiation.
Right, because they're aware of the consequences, not just cancer, but all those other things you talked about that are not pleasant. So.
And I have to say, I'm pretty sure that is not the first thing on a child's mind when they're thinking about whether to have sex, whether it's going to lead to cancer down the road. That's not their worry. This has been a really interesting discussion. I thought we'd have trouble filling the time. We're at the end of our time. I am blown away by your knowledge and your ability to articulate it. Lisa, this has been a great opportunity to talk to everyone about how best to prevent cancer, which in the end is an amazing goal. Everybody has this goal. Nobody wants to get cancer. We've heard a lot from you both about the maps that you've drawn, the way you can make a visual picture of the disparities and the costs to our society. Dr. Wallington, Dr. Paskett, thank you so much for your discussion. Lisa, thank you so much for the opportunity.
And I want to thank each of you for being part of this discussion today. I want to thank our viewers. I'm hoping that I love that we ended on talking about a success story, which is, the HPV vaccine and ways that we can make practical steps to increase the uptake. And we need to continue our work together as professionals and all of the people watching today in congressional districts and congressional offices to figure out how we can continue to take steps to help people prevent cancer or detect it early when it's most treatable. Thank you all for watching, and we will look forward to continuing our work and staying in touch. Thank you. And thank you to NAB, of course. Thank you.